Hello viewers. Let me start this video with a small event. We are caring for a patient who arrived in acute respiratory failure requiring rapid sequence intubation. Establishing the airway itself was not problematic and no airway abnormalities were seen during intubation. After stabilizing the patient, you step out of the room to tend to care another ill patient. Sometimes later, a colleague nurse from your patient unit notifies you that the ventilator alarms keep going off and everybody is busy in caring other patients. Being the centered and disciplined critical care nurse, you are stepping into the room to begin systematically evaluating the situation. So this video will help you to review common causes of triggered ventilator alarms and how to troubleshoot these issues. So here we are going to discuss about ventilator alarms. So let me tell you the objectives of this video. At the end of this video, viewers will be able to understand the basic pressure curves, identifies the troubleshooting alarms, and initiate measures to rectify ventilator alarms. So ventilator alarms, what, when, who, where, and how to troubleshoot these ventilator alarms. So before going into the ventilator alarms, let us understand the pressure time curve. While you may notice several waveforms on the ventilator, each with their own nuisance, a fundamental understanding of the pressure time curve is important for the emergency care or critical care nurse. Pressure is created when there is flow directed into a closed system, such as the lungs. Resistance is created in the system from the endotracheal tube, the airway, the chest wall, and the lung itself. Generally, there are two pressures that we need to be familiar with to understand this. One is the peak pressure, and another one is the plateau pressure. So the peak pressure is the summation of pressure which is generated by the ventilator to overcome airway resistance and alveolar resistance to attain peak inspiratory flow and to deliver desired tidal volume. And simply, it is the airway pressure delivered by the ventilator to initially overcome the resistance of the endotracheal tube, airway, and alveoli. As we may recollect, the understanding of basic physics, that is resistance to flow, is inversely proportional to radius. Peak pressure is graphed as a summation of both initial airway resistance and lung compliance. In general, an acceptable maximum peak pressure is 40 centimeter water. Next type of pressure is the plateau pressure. It is the pressure in the lung after a certain volume of air is delivered into the lungs. This is measured by doing an inspiratory hold, which effectively eliminates any airway resistance. And this is a gross reflection of the lung compliance or the stiffness. The main determinant of plateau pressure is compliance. This may be easier if you think there are inversely proportional. If lungs are very compliant or stretchy, then the resultant plateau pressure reflected will be lower. The opposite is true of stiff lungs or low compliance. So what is compliance really? Compliance is simply the change in volume divided by change in pressure. If the patient is having a large change in volume with low pressure change, compliance will be high. And compliance plays a big role in both calculating peak and the plateau pressure. In general, an acceptable maximum plateau pressure is 30 centimeter water. Changes in airway resistance and compliance can affect the pressure time curve. So after having a basic information about this pressure time curve and its component of peak pressure and plateau pressure, let us move into the troubleshooting ventilator alarms. During ventilator troubleshooting, we always remember the mnemonic called DOPES, which means check for dislodgement, obstruction of the endotracheal tube from mucus plugs or from patient biting on the tube, pneumothorax, equipment malfunction, and stacked breaths are patient ventilator dyssynchrony. So here in this video, we'll be going to discuss beyond DOPES so we can gain an understanding of the different alarm types its etiology is triggering the alarms, while different ventilator will use different displays or alarm configurations. The below concept hold true regardless of any model. So let us going into the different type of pressures, how it can create a ventilator dyspnea with the patient. So first kind of pressure change is the low peak pressure. So whenever we see the alarm low peak pressure, think air leak. The ventilator alarm is alerting you low peak pressure or simply low pressure. Means there is a leak in the system and the ventilator is not able to generate the peak or plateau pressure necessary to oxygenate or ventilate the patient. So what could be the reasons for this low peak pressure? Again, think air leak. So what are the reasons or how the air leak can occur? It can be due to the disconnected tubing, a cuff leak, or a hole in the tubing, either in the endotracheal tube or in the ventilator tubing, a leak in the humidifier. But we also have to think about two more reasons for the low peak pressure. One is the chest tube leak. Suppose the patient is having a chest tube drainage, there could be holes in the chest tube, distal chest tubes. Then there are no leaks in the tubing or connections, you need to check it. Consider repeating a chest X-ray and advance the chest tube as required. The second point is the bronchopulmonary fistula. It is a rare case. Consider in patients with a history of tuberculosis, radiation therapy, chemotherapy, or patient who have undergone lung resections. This can be diagnosed via the bronchoscopy. So along with these 4 points, you also have to check presence of the chest tube leak or the bronchopulmonary fistula in case. The second kind of pressure change alarm is the high peak pressure and normal plateau pressure. If you see this kind of alarm, then think the resistance. The ventilator is showing isolated high peak pressures. Then there is resistance in the endotracheal tube or distal bronchus, which may cause a smaller diameter and requiring the ventilator to increase pressure in order to deliver the same breath. When taken off the ventilator, these patients will have increased resistance with the manual ventilation, that when we use the ambu bag. That reasons for this high peak pressure and normal plateau pressure is already I told you the resistance. So the causes for this resistance are increased secretions, kinked ventilator tubing or endotracheal tube, patient biting the endotracheal tube, water in the ventilator tubing, endotracheal tube advanced into the right mainstem bronchus. And the third kind of pressure alarm is high peak pressure, high plateau pressure. So when there is both high peak and the high plateau pressure, think compliance. Here, the ventilator is showing high peak and the plateau pressure. There is an issue with the compliance of the lungs, which may require the ventilator to increase the pressure delivered. These are the most common type of ventilator alarms. So the reason for this high peak pressure or high plateau pressure is something related with the lung compliance. That can be due to the evolving pneumonia. The patient is on long-standing ventilator. The patient may go into the ventilator-associated pneumonia, pulmonary edema, autopnea, which is caused by the breath stacking in patient with progressively increasing PEEP and often seen in obstructive sleep apnea, COPD, and reactive airway diseases. Or this may be due to the inappropriate PEEP levels, stridal volume, or ventilator dyssynchrony. Next is the right mainstem intubation. Sometimes the endotracheal tube, which may enter into the right mainstem. So then we have to adjust the position of the endotracheal tube. Next is the tension pneumothorax, which can be caused by the barotrauma or valve trauma. Then we have to watch for hypotension and immediately consider disconnecting the patient from the ventilator and the emergent decompression with thoracostomy. Change is the hypoxia without the change in ventilator curve. In this case, you have to think about shunt. This is generally caused by dead space ventilation or poor perfusion. Consider an intracardiac shunt, pulmonary embolism, AV fistula, hypovolemia, and stroke state. The fifth type of pressure alarm is the high and low rate alarms. If the respiratory rate increases or decreases beyond the set alarm rate, these alarms will trigger an audible or visual alert alarm. In case of low rate alarm or apnea alarm, backup ventilation may be provided depending on settings. An agitator or fatigue patient may have an increase in respiratory rate. Sedated patients or patients with impaired neuromuscular function may also have a decreased respiratory rate. The sixth type of pressure alarm is the high and low expiratory volume alarm. High volume expiratory alarms may indicate a high respiratory rate as well as increased patient demand for air because of pain, anxiety, or improper ventilator settings. Low volume expiratory alarms typically are caused by air leaks. The next type of common alarm is the high and low inspiratory volume alarms. High volume inspiratory alarms may indicate a leak or disconnect, high respiratory rate, or increased patient demand for air. Low volume inspiratory alarms may be caused by mucus plugging, need for suctioning, tube obstruction, a slower respiratory rate, or shallow breathing. So how can we manage this troubleshooting ventilator alarms? So whenever we approach the patient to attend for any care, we need to perform the common protocols or common personal protective hygiene. So always perform hand hygiene and wear gloves and wear additional PPE based on the patient need for isolation precautions or the risk of exposure to body fluid. If time permits, verify the correct patient using two identifiers. If you can identify the reason for alarm, then you can attend. Suppose if you are not able to identify the reason for alarm immediately, then you can do the manual breathing unless or until the alarm can be corrected, or explain the procedure to the patient. So now we will see how each of the troubleshooting alarms can be managed. The first kind of troubleshooting alarm we are going to discuss is the ventilator inoperative, that is vent inop. If you see this kind of alarms, immediately turn the ventilator off. Instructions on the ventilator if available. Meanwhile, you can do the manual respiratory support to the patient. The ventilator fails to operate properly, tag it for maintenance check and replace it with another ventilator. Ensure that the ventilator settings and alarms are set properly. Make sure the alarm has been corrected and the patient is stable. The next type of alarm that you could come across rarely is power failure. If you see the power failure alarm, assess the ventilator, ensure that the power cord is plugged into an electric outlet that is connected to an emergency backup power source. If the external or internal battery is low, reconnect the ventilator's power cord to an electric outlet. If applicable, check the fuse or circuit breaker by replacing the fuse or pressing the reset button next to the circuit breaker. Ensure that the ventilator settings and alarms are set properly. Verify that the alarm has been corrected and the patient is stable. Once rectified, then you can leave the patient side. Next is no gas delivery to the patient. Very rarely, this may also happen if we don't check all these parts in the ventilator before connecting the ventilator to the patient. So if you find a no gas delivery alarm, ensure that hoses are tightly connected to the appropriate gas source. Just check the oxygen and air pressure. The gas pressure gauge is located at the gas shutoff valve for the unit. Check the cylinder tank gauge if using gas cylinders. Ensure once you correct all that, the alarms are set properly and the patient is comfortable and adequate ventilator parameters are working. The next is the low positive inspiratory pressure. Check the circuit for leaks or disconnections. Tighten or reconnect the connection. Check the patient's artificial airway curve for leak or deflation. Check the humidifier for leak or disconnection and tighten or reconnect. Check the inline success system for leaks or disconnection. Replace that if you find leak or disconnection. Also, we need to check the inline adapters for meter dose inhaler or small volume nebulizer for any leaks or disconnection, then tighten and reconnect it. And check for chest tube leak if one is found. Consult the practitioner for further intervention. Ensure that the proximal pressure line is connected and unobstructed. Ensure that ventilator settings, alarms are set properly. Verify that the alarm has been corrected and the patient is stable. Next is low tidal volume. Check the circuit for leak or connections. Tighten or reconnect the connections. Check the artificial airway cuff for leak or deflation. In this case, you may also have to check the cuff pressure and listen for an air leak in the patient's trachea. Identify and correct the cause of the leak. Check the humidifier for leak or disconnection. Check the inline suction system and the small volume nebulizers. Check the chest tube. Ensure that the ventilator settings are set properly, alarms are set properly. Then after verifying everything is corrected, then patient is stable, you can leave that patient. Then the low minute volume. Assess the patient respiratory rate and clinical condition for apnea, low respiratory rate or low exhaled tidal volume. If necessary, contact the intensivist and correct the clinical problem. Begin manual ventilation if patient is apneic. Check the circuit for leaks or disconnections. Tighten or reconnect the connections. Check the patient's artificial airway cuff for leaks or deflation. Check the cuff pressure and listen for an air leak in the patient's trachea. Identify and correct the cause of the leak. Check the humidifier for leak or disconnection and tighten or reconnect the connection. Check the inline suction system, MDI or meter dose inhaler or small volume nebulizer for its disconnection, tighten and replace it. If the patient is on chest tube, check the chest tube leakage. After that, once everything is corrected, check the ventilator settings and alarms are set properly and the patient is stable. Next, PEEP and the CPAP variations. Check the circuit for leak or disconnections. Tighten or reconnect the connection. Check the patient's artificial airway cuff for leaks or deflations. Check the cuff pressure and listen for an air leak in the patient's trachea. Identify and correct the cause of the leak. Check the humidifier for leak or disconnection, then tighten or reconnect it. Check the inline suction system. Check for the inline adapters for meter dose inhaler or small volume nebulizer. Check for the leak or disconnection, then tighten and reconnect it. If the patient is on chest tube, again check or consult with the intensivist. And also ensure that the proximal pressure line is connected and unobstructed. And check the exhalation valve for leak. If again valve leak is found, an external exhalation valve is in place, replace the circuit and the ventilator. After all, check the ventilator setting and alarms, make sure the patient is stable. Next is apnea alarm. Assess the patient's breathing. The patient is apneic, begin manual ventilation, that with the manual rebreathing mask bag. Assess the patient's clinical condition for causes of apnea and contact the intensivist, correct the clinical problem. Check the ventilator sensitivity settings to ensure that detects the patient's inspiratory efforts. Check the circuit for leak or disconnection. Ensure that the ventilator settings or alarms are set properly. Then make sure the patient is stable before leaving the patient unattended. Next, inspiratory-expiratory ratio alarm. Ensure that the inspiratory time is set appropriately. An inspiratory-expiratory alarm usually indicates inverse IE ratio. Ensure that the flow rate is set appropriately. Patient's respiratory rate need to be checked. Ventilator alarms and the ventilator setting should be set properly before leaving the patients unattended. High minute volume. Assess the patient for signs of respiratory distress. If any respiratory difficulty or distress is found, take the appropriate action to correct the cause and call the intensivist if required. Ventilator settings and alarms need to be set properly before leaving the patient unattended. High pressure limit. Assess the patient for signs of respiratory distress. Attempt to pass a suction catheter through the patient's artificial airway to check for any obstruction. This can be due to the tube being repositioned to straighten it. If the patient bites the tube, consider placing an oral airway airbite block. The tip of the artificial airway has impinged on the tracheal wall, reposition tube for free of obstruction. For all other obstruction, attempt to clear the tube with a suction catheter. Check the ventilator circuit for water, drain condensation away from the patient and towards the expiratory limb. Check the ventilator circuit for kinking and obstruction. And you also have to check for the bronchospasm, secretions and the pneumothorax. Check the exhalation valve and filter for failure. If it is so, do it. Appropriate action. Make sure that the settings and alarms are set properly and the patient is stable. High respiratory rate. Assess the patient for signs of respiratory distress. If distress is found, take appropriate action necessary. Call the intensivist. Ensure that the ventilator settings and alarms are set properly and patient is stable. Low or high FiO2. Check the gas source to ensure that the ventilator is connected to a high pressure oxygen source. Ensure that FiO2 is set properly. Recalibrate the internal oxygen analyzer if able to do. Check the FiO2 with the calibrated external oxygen analyzer. If the correct FiO2 is not being delivered, replace the ventilator. Ensure that ventilator settings and alarms are set properly and the patient is stable before leaving the area. So after doing all this, for everything, nurses alone cannot be doing it. You have to call either the biomedical engineer or the airway therapist or the intensivist to attend all these alarms. As a nurse, we can perform any actions within our scope of practice. Once it goes beyond the scope of practice, please contact the necessary healthcare professionals or the paramedical people to attend the ventilator. So ongoing care requires ensure that the patient's artificial airway is patent and secure. Ensure that ventilator settings and alarms are on and set appropriately. Keep the ventilator tubing free from condensation, drain tubing away from the patient and toward the expiratory limb or water trap. Check the alarm settings at regular intervals during a ventilator system check. Observe the patient for signs of and symptoms of pain. If pain is suspected, report it to the authorized practitioner. To conclude this ventilator and alarms, ventilator alarms are a common occurrence both in post-intubation and chronic ICU patient. Alarms can be the first sign of an acute process and should be addressed immediately. When in doubt, take the patient off the ventilator and manually ventilate the patient. If the patient gets better, it's likely the ventilator, the interface, or the settings. Suppose even after doing this, the patient doesn't get better, consider an issue with the patient or with the endotracheal tube. Analyze the issue, attend it properly before we could leave the patient with the ventilator. So as a nurse, the take-home message is never ever silence the alarm without knowing the reason. Either the alarm can be due to the ventilator settings or the patient parameter or the support system like the gas cylinders or the pressure points or the electrical outlet. So please identify the reason for alarms, attend it. Get the help from the biomedical engineers or the respiratory therapist or the intensivist before everything gets settled. So be careful when you see or be attentive when you hear or see a ventilator alarm at any point of care in the intensive care unit. Hope this video has helped you to learn something better about the ventilator alarms. So these are some of the references made to prepare this video. Thank you.